All right, chapter 4, the social demography of health, social class. All right, this chapter is our kind of the first one in our next unit. The first three were kind of an introduction to the core or to the subject matter and a discussion of epidemiology and, well, COVID-19. Now we're moving on to more of a social determinants of health unit. We're starting with social class. Why social class? Well, as you'll see, I'm going to go ahead and start the slideshow for you. We will see here that it is because all over the world, social class is the strongest and most consistent predictor of health and well-being. Now, race, age, and sex all have important effects, and we will be discussing them in later chapters. But the effect of social class remains even when controlling for these factors. Now, what's controlling mean? That's statistics nerd talk for accounting for. In simple terms, what it means is even within racial groups, for example, social class has this effect on health. So even among minority group members, the more well-off members do better than the less well-off members. Even age, for a given age, say 54-year-olds. Well-off 54-year-olds are doing better than not so well-off 54-year-olds, many of whom are actually dead, right? Sex is the same thing. So that's what they mean by controlling for. At each level of these variables, we still have this effect. Little statistics lesson for you there. So, moreover, this socioeconomic status, or social class, as is put, is the strongest and most consistent predictor of health across the life course, regardless of access to healthcare, or even the healthcare delivery system generally. So it's not just a matter of, well, they're poor, they don't go to the doctor, and they die. It's a little more complicated than that. I mean, it's part of it. I mean, not going to the doctor certainly doesn't help matters, but doesn't explain all of it, or even most of it. All right, so before we delve into our research on the relationship between social class and health, we should talk about how we define social class. Now, social class, here's your textbook definition of it. It's a category or a group of people who have approximately the same amount of wealth, status, and power in society. Why those three things? It always goes back to a German dude named Max Weber, whose conception of socioeconomic status or social class, he was kind of building upon ideas that probably kind of predated him, although I don't think he really knew Karl Marx. But the idea of class, meaning more than just simply position in the economic system, or at least in the Marxian sense. He added these other ideas to it. It's money, of course, but also includes other things like status. How revered are you in your society? What position do you hold? And power, which is, I think he defined it as the ability to get people to do stuff they don't want to do, right? Which I guess is probably one of the best definitions of power I've ever heard. So there you go. Now, using this Weberian model, in the U.S. anyways, we end up with this 5-class model. Now, other places, there's other ones too, but most of the time in the U.S. we use this 5. We have the upper class, right? That's your 1%ers. You have your upper middle class. That's your like $250,000 a year people. Your successful doctors and successful lawyers and hedge fund managers and things like that. Then you have your you have your lower middle class. That's probably yours truly. You get to the working class. This is trades. Although a lot of times those trade positions actually work people right up into that lower middle class too. But again, the working class, it's not the lower class, that's your minimum wage employees or the chronically unemployed. Now, Europeans do things a little bit differently. They tend to focus on the occupational differences as their chief component of class position. That's how they do it. They don't really work about the status and power stuff. Now, some of the scales have 10 classes. I think if you look at the WHO one, it's like 10 of them. But again, American sociologists usually rely on this SES model, which is again influenced by Karl Marx and probably more so Max Weber. Can't give Karl credit for all of it. So, now wealth again is an important component, right? That's the Marxian element of all this. But including status and power allows us to measure all the social class using 3 variables, not just money, right? We do use money. That's the first one, right? But also these other things, occupational prestige. That's your status variable, right? And how that is, there's they do these national, international surveys where people rank how prestigious people think certain jobs are, right? At the top, you have like, Supreme Court Justice, well, it used to be Supreme Court Justice or judges generally, doctors, lawyers, that kind of thing. At the bottom, you have like, I don't know, drug dealers and congressmen and things like that, right? And in the middle, everybody else kind of falls in. And then, of course, you have education, right? And that is just what it sounds like, how many years of education one has. Now, interestingly enough, out of all these three measures, education is the one that's the most important in predicting health outcomes. It's the one that predicts it the best, the strongest one. If you do the statistical magics, we get the bigger coefficients with education and more consistently. Now, why? Why is that? Well, there's a few reasons why. Now, one of them, I'm not sure your book really talks about this, but education is a pretty good proxy measure. And proxy measure means that, you're not measuring something directly, but you're kind of measuring it indirectly, of social position. The more education one has, generally speaking, more likely they are to live in, nicer neighborhoods and go to better schools and better shopping options and that kind of thing. But that's not it, though. I mean, some people do just fine without a lot of education. Some people with a lot of education aren't doing so great. So, it's part of it, but there's all these other parts as well, which we're going to talk about here. Knowledge about healthy lifestyles, right? It kind of seems like everybody knows, but it's not so much knowledge. Well, it is partly knowledge, but it's also the understanding that these healthy lifestyles are actually worthwhile, right? That it's not just a fool's errand, that it's something that you should do, and it's actually a worthwhile endeavor. Again, this is going to be more common among the more highly educated. Seeking preventive care or medical treatment for health problems when needed. Again, this is the idea that they more well-educated folks understand the need for preventive care and also have access to it, and also have jobs they can take off to go to these preventive care things and so on, right? And of course, like I've already mentioned, likelihood of having better income and, satisfying jobs. Another point there, satisfying jobs. Those in the knowledge economy tend to be a little bit more pleasant than, say, the ones where you have to work with your back, unless that's your thing. So, now, the importance of these individual components of SES, income, occupational prestige, and education, the importance does tend to vary over the life course. We'll talk about the life course in another chapter, but we just mean over a person's lifetime, right? So, yeah. So education here, for example, influences the onset of chronic diseases. The more well-educated folks, doesn't mean they won't get chronic diseases, but it does mean it'll take longer for them to come to, rear their ugly head, right? Now, income is more important later in life. So once you have these chronic conditions, you can be all educated as you like, but if you don't have any money, we have a lot more difficulty trying to navigate these chronic conditions, treatments, housing modifications, direct caregivers, that kind of thing. So, now, life expectancy, unsurprisingly, is greatest for people with high incomes. We covered this pretty well, but I just want to reiterate. Now, the disparity has actually increased in recent years, not decreased, increased in recent years as, the gap between the rich and the poor has increased. So they're both kind of two lines trending away from each other. And especially, this line between the educated and the non-educated. Let's see here. Before I go to this one, I'll come back here. So you see here, your book, I think, goes on to talk about, the groups that have been especially impacted. I don't know if it's in this chapter or another one. Sorry, folks. So they kind of bleed together to me sometimes, but I'll tell you now. In case it comes up later, I'll just repeat myself like the old man that I am. The particularly hard-hit groups here have been rural folks who are poorly educated. They have seen their life expectancies stall out. Their life expectancy gains stall and even kind of go backwards more so than every other group. So it's actually the one group, I believe, was it poorly educated, rural, white folks, particularly white women, I think. You might want to check your book on that one, but I believe that's the group. And it doesn't seem intuitive, right? But it's how it's playing out. There's this big kind of this, what they call it, a rural penalty going on there. So men in the top 1%, now we'll just go out of the rural urban stuff, just generally, men live 15 years longer than men in the poorest 1%. So we're talking about 15 years of life. That's considerable. Now, of course, where you're poor also matters. If you're poor, but you're kind of within proximity to the wealthy and cities, they tend to do better. It's better to be poor in New York City than it is to be poor in Tulsa, right? There's more stuff in New York City, more services. And again, and largely explained also by health behaviors. New York City, it's a walking city. You're surrounded by kind of the norm of relatively healthy behaviors. Tulsa is a little bit different. Even though it's a city, it's just not as big. Now, also, one thing we should note here, where you're poor also matters, but why is this? Why are we getting at these big gaps? We've already talked about some of it, but lifestyle related. But we also have this issue where the poor have the greatest exposure to risk factors that cause ill health. So you have your physical ones, like poor sanitation, bad housing, overcrowded housing. You have your chemical factors, pollution. You have biological factors like bacteria and viruses. What else do we have here? Oh, here's a more extended one. Psychological ones. We have stress, economic risk factors, low income, lack of insurance, unhealthy jobs, and yes, lifestyle, which we've already kind of covered. Poor diets, higher rates of smoking, that's a big one actually, and lack of leisure time exercise. Sounds frivolous, but you'd be surprised at how important that is to keep you alive. Now, going back to healthcare coverage, access to care did improve under the Affordable Care Act, what the media likes to call Obamacare, right? But the law is politically controversial and is regularly challenged, although recently it's been holding up. Who knows what will happen in the future? Now, it has, again, has resulted in a number of uninsured Americans drop considerably. There are still plenty, though, who are uninsured. But health insurance is really only part of the solution. It is part of it, clearly. But really, the importance of health insurance isn't so much for the care that people get. People will get care, maybe not preventive care, but they'll get care eventually in ERs and that kind of thing. It's that the numbers of bankruptcies and economic fallout that comes from not having health insurance. It used to be before, this Affordable Care Act. Medical bankruptcies were wildly common. They're a little less common now because of this, and also some other rules are implemented about how these debts are handled. But I digress. So, if we want to address the poor health in the poor, you also need to look at other things, like norms, which are accepted ways of behaving. When I say behaving, food choices about exercise, smoking, drinking, refined sugars, whatever, all saturated fats, all these things you're not supposed to do. How acceptable are they in that community? And again, it varies from area to area, and not just from class to class. We also have poor living conditions. Again, that's more of it's not a health insurance issue. That's again a structural issue. Lower levels of agency, along with higher levels of fatalism. This kind of goes back to the norms. And the idea here is that poorer folks generally have less control of their lives than people who are more affluent. I'm here to tell you that's kind of true. Even if you're not very well off, or you're just well educated, the more education you get, the more free time you have. Well, not really free time, but more time you get to self-direct your day, right? You don't have a supervisor clocking you every few minutes, making sure you're in the bathroom for 15 minutes, no more. That kind of thing, right? That doesn't happen, the further up you go. And so what that does, it kind of fosters this idea of, you have this control of your life. For those of us who've gotten a little bit further up the rungs. Now, people a little further down don't really experience this agency, as it's known, this ability to call one's own shots. And so the worldview that's kind of fostered in this scenario is one of fatalism, meaning it's fate. Whatever's going to happen, fate's going to have it happen, regardless of what I do, right? And you can see how those kinds of, how one mindset, the one where you have control over your fate, right, that would lead to different kinds of health behaviors. The one is like, the universe is going to do what it's going to do, right? And so there you go. And again, these are kind of deeply rooted, beliefs that are rooted not only in just, cultural quote unquote beliefs, but also in the position within the economic system reinforcing it. All right, so what kinds of diseases are we talking about here, by the way? So we're still, most of the time when we talk about this sociological study of the social determinants of health or what have you, we're talking usually about chronic diseases. Yes, infectious diseases have been a big deal the last couple of years, but generally speaking, most of the health problems people experience are these chronic illnesses. And They used to be associated with the upper classes back when, right? You had to have enough money to live that poorly, right? Now, what's happened over the years, lifestyle changes among the affluent, they've stopped doing all these things, or at least most of it. But the poor now, because again, all these things have been made very inexpensive, they are the ones now eating these, fatty diets, drinking too much, smoking too much, that kind of thing. Now, and as a result, the lifestyle has kind of shifted. The poor have actually a better lifestyle just because, well, it's hard to eat poorly when you can't eat at all, right? So things have changed. And now we have these chronic conditions certainly being now a product of, being poor, primarily, at least the early onset of them. You live long enough, you'll get a chronic disease, but the idea is when it onsets. Now, the poor are, again, more likely to suffer from, we've already covered infectious diseases. Now, they're much more likely to also suffer from chronic diseases, and finally, mental illnesses, especially schizophrenia. Now, that's a tricky one to measure the causal direction on. Is it that the schizophrenia, is schizophrenia the result of them being poor, or are they poor because they're schizophrenic? And again, chicken and eggs, a lot of surveys aren't really designed to figure that out. Surveys, when they're given, are kind of snapshots at one point in time, so you can't tell what happened first. You only know both things are happening at the same time, which makes it difficult. All right, so Richard Wilkinson's income inequality hypothesis revisited, right? So we've established that, the further down the social hierarchy one gets, the social class hierarchy one gets, the worse their health and the more likely they are to die. Now, Wilkinson's theory or hypothesis was that it wasn't even so much that it's not this absolute amount of poverty, right? It's not about, it's not absolute poverty, it's relative poverty, meaning that it's not, again, they could be a relatively well-off country, but we'll still see this gradation with the poor, relatively poor, still having this effect, right? And so, again, he talks about it being a matter of inequality. It's not so much about actual on-the-ground deprivation. Now, again, he says, so society's overall level of wealth is less important. But one thing I will point out is that, this is kind of an ongoing conversation. There's so far findings and other research, some have supported, but a lot of it has not supported his position. More evidence to support an absolute poverty thesis has been presented in recent years, meaning, again, there's a certain threshold at which it doesn't really matter, if you're relatively, where you are relatively in the social hierarchy. At some point, deprivation is deprivation, right? Now, I'm not going to wait. I can't, give you a definitive answer here, which one's correct or not, because it's still an ongoing scientific debate. I guess if you were to ask me, I would probably subscribe more to the absolute poverty thesis myself. But again, that's just my reading of it. The other papers do make good cases too. So what's the answer? Well, I don't know. But it's something you can think about. Is it a question of inequality, or is it a question of actual, deprivation? Not having stuff. That's the question there. And, I guess the answer to that would be whether or not you think it's more of a question of the psychology of all of it, the feeling of being poorer, or is it really the material conditions of being poor? You could take a materialist approach or more of a postmodernist approach. It's up to you. What answer it is, well, we'll see. Now, equality of care and the social gradient of mortality. So the British experience. So we talk about all these social gradients. We talk about healthcare in the United States being what it is. And the question always becomes, what would happen with a nationalized health service, right? Well, Great Britain did this. It was after World War II. It was a long time ago. But they introduced socialized medicine, the National Health Service. And it provides the lower classes with the same medical care as the upper classes, right? There's no difference. The doctors are the doctors. And only access to healthcare only access to healthcare was equalized. They didn't redistribute wealth or anything. Great Britain didn't become a communist country. They just made the access to healthcare equalized, and everything else was unchanged, right? And so, Great Britain has a pretty rigid social class system. They actually talk about social class there more than we do here. It means more to them in day-to-day conversation. Now, what they found was that the equalization of healthcare alone did not reduce the disparity in health between the social classes, right? That's where we got back from those early slides on saying, access to healthcare wasn't the panacea to this problem. Well, that's because they've already tried it. They did a report in 1980 it was a long time ago, I was just a little boy, called the Black Report. And it assessed the trends in population health. And what they demonstrated was that these health inequalities were not decreasing. And this is, again, decades after this National Health Service had been established, that these inequalities were not decreasing among the different social classes, again, despite these increased welfare services. Now, follow that up some time later with the Whitehall studies. This was a study on British social servants. And what they wanted to look at were social class differences in mortality among these male civil servant employees in Great Britain. Now, what they found was that regardless of the cause, those with the highest occupational rank had the lowest percentage of deaths, period. Now, mortality increased across each job category on the way down. Now, the lowest rank occupations had the highest percentages of deaths. And this is where they get this idea of it being about inequality, the hypothesis. Because if you look at this, in Great Britain, in their civil services, there's not a huge pay difference between the top of the civil service and the bottom, right? It's there, but it's not a huge one. It's not like, the difference between, your average Amazon worker and Jeff Bezos, right? And it's a much, much smaller window. It's much, much tighter. So the difference here isn't so much about necessarily resources as much as it is about other things. So, and to kind of illustrate this point even more, this social gradient that they found was observed even among relatively highly ranked groups, right? There's no deprivation there. But you can still see the second richest were slightly more likely to die than the actual richest, and on it went. Again, these differences were linked to hierarchy rather than deprivation. And so this is where the hypothesis came back, the Wilkinson hypothesis. Now, again, it was observed in numerous countries, regardless of the specific variable used to indicate social position. Now, there's lots of reasons for it. There's self-esteem and stress levels, which we'll discuss actually in this chapter on social stress and health. The effects of income inequality, which we're talking about now. Deprivation through the life course, which is, again, that's another chapter. We talk about age and race later on. Health, lifestyles, and social support, we'll talk about those as well. The socioeconomic environment, yes, we have a chapter on that as well. And finally, the use of preventive health services, which we'll also touch upon. So, other things, before we wrap this up, that kind of goes back to the socioeconomic environment that we haven't really talked too much about to this point, is neighborhood disadvantage. Now, neighborhood disadvantage is an interesting measure because it captures a lot of things, right? It's the lived environment, the physical environment, but it's also a measure of social class. And the surroundings at home, the workplace, also, going back to the urban-rural business, we talk about services that are provided to support people, the sociocultural aspects, and of course, reputation, right? Now, orderly neighborhoods that are clean and safe, even if they're not very well off, right? Where the houses and buildings are well maintained, the residents are relatively respectful of each other and each other's property. Those places are associated with better health outcomes, again, controlling for these other factors. Disorderly neighborhoods, on the other hand, they're associated with higher rates of death and disease. And all of this brings us to the final point, I believe, in the chapter, is socioeconomic status, or SES, as a fundamental cause of sickness and mortality. And what they mean is that SPS can be described, again, as a direct cause of poor health because I'm going to give you a list, it influences multiple diseases. It works through multiple pathways of risks. It's reproduced over time. It keeps happening year after year after year. And it involves access to resources that can be used to avoid risks or to minimize the consequences. So, the degree of socioeconomic resources a person has or does not have, such as money, and again, we're including other stuff too, knowledge, status, power, social connections, all these things either protect health or causes premature mortality or morbidity as well. And there you go. There's your lecture on social class and health. It's probably, much as you expected it to be. It's not like we were expecting the poor to have better health. But I hope that you see that it's not as cut and dry as it could be made out to be by some. There's a lot of factors going on, a lot of nuance to this, and we're going to discuss, as we discuss these other topics within the social demography of health, age, race, gender, we'll see how they intersect with social class to start to create, more, I guess, detailed hierarchies of health and well-being. All right, folks, that's what I have. Until next time.